Thank you, Aditi, for having me in this session. And that was an excellent presentation by Dr. Abhishek. So I'll be talking about a simple device which I have invented, which will shorten the uh, pain of amniotic membrane transplantation in the acute setting for both the patient and the doctor. So we know that the human amniotic membrane has been used for quite some time on the ocular surface in the acute setting as well as for SLAT and other chronic settings. So we are interested only in the basement membrane part of the amniotic membrane because we know that it has got uh, anti-scarring property and anti-inflammatory property. The amniotic membrane has been used extensively in the reconstruction of the ocular surface in conjunction with stem cell transplantation and as a conjunctival substitute following removal of pterygia, conjunctival lesions, and symblepharon release, etc. The most important use of amniotic membrane where it really makes a difference is acute chemical burns, which we are discussing, and acute Stevens-Johnson syndrome also. So as Abhishek has already touched upon this, I will not dwell on this, but the importance of amniotic membrane transplantation are in grade 4, 5, and 6 of Dua's classification for acute injuries, and in acute SJS, we follow Gregory's grading, in which the severe and extremely severe, that is more than 1/3 lid margin involvement with any epithelial defect more than a PE on the cornea, and a stain positive of greater than 1 centimeter on the palpebral or bulbar conjunctiva is considered to be severe or extreme. And in that case, we follow this algorithm where in the severe and the very severe category, amniotic membrane transplantation is life-saving for the patient. The conventional process of amniotic membrane, which is being shown in acute Stevens-Johnson syndrome in this case, suffers from certain issues. And these issues are that it is extremely painful for the patient because often the patient is in the ICU setting and very little can be done by way of anesthesia. And it is a laborious process for the surgeon who has to do it without the help of the microscope. So, several people have tried to come up with different devices. Prokera is one such device. And here you can see Prokera, but the problem of Prokera is, other than being expensive and not readily available in our country, this covers only about 2 millimeters beyond the limbus. So the main problem in chemical injuries and SJS lies in the fornices and the bulbar and lid conjunctiva. So those are not addressed. So one team from Massachusetts, I have tried to use infant feeding tube, which is tucked into itself to form a variable sized ring, and then the amniotic membrane is draped on the eye and the ring is tucked in so that the AM goes inside. But the problem of this is that when you are laying the amniotic membrane on the eye, it becomes unsterile and the tube tends to come out. So we felt that there was an unmet need in this area, and we needed a device which could be assembled in the eye bank or OT at the bedside, stored like a regular AM under topical anesthesia, and used at the bedside. So we went through certain design iterations, and finally we ended up with having it being manufactured from Aurolab. And this is the milling process. It's simple. It is made out of PMMA and can be manufactured easily. So this is the final avatar that is being marketed now by Aurolab. I have no financial interest in this, and it comes in two parts: a bottom part and a top part, and they are separately packed in ETO packages. So now what you can see on the left side of your screen is the bottom part is laid down. There is a notch over here onto which the top part goes. I am showing a dry assembly first. So the top part will simply go and snap fit into the device. Now to attach the amniotic membrane to this device, over here, what is being shown is that the device is fairly compressible. So we have it in one size only, and it has been seen that because of this compressibility, it fits into fornices of different sizes. So to attach the amniotic membrane, you tuck the device under the amniotic membrane, the bottom part, and then simply bring the top ring, and it snaps in, and it becomes one assembly which can be used with the hand or with a forceps and directly inserted into the eye like a contact lens. There is an alternative technique in which you put the bottom part on top of the amniotic membrane and bunch the amniotic membrane internally and then seal the top part. The advantage of this technique is the edge of the lower part which goes into the fornix is also covered by amniotic membrane. So this is a case in which of chemical injury which was done by Dr. Rishi, who will be presenting later, and it just shows that you can do amniotic membrane transplantation in a matter of minutes, even in the acute setting. This is another case in which the amniotic membrane is being done in the PICU for a Stevens-Johnson syndrome child. And you can see that this is being assembled on the gloved hand of the surgeon. Although ideally it should be done under the microscope in the OT or away from the gloved hand to maintain sterility further. And you can see that over here, Dr. Bhupesh, who did the surgery, is pulling the excess amniotic membrane outside and also draping the lids. So it can be used like a conformer under topical, and you can also use the excess amount of amniotic membrane if you're using a large sheet to drape the lids, which is an important consideration, especially in Stevens-Johnson syndrome. So this is another case in which the amserter was used, and you can see it really makes a difference because it prevents synechia, symblepharon formation, and promotes epithelial healing. So really the eye gets saved, because we all know by now that amniotic membrane in the eye in the acute stage of chemical injuries or SJS really makes a difference for the patient. And you can prevent almost all the chronic sequelae if you have done an amniotic membrane within the first 48 hours. So here are some more cases of use from across India. And this was a case of Chuna injury, which is, as Abhishek said, is very common in our country. And these are the results. So it really goes a long way in preventing symblepharon and promoting epithelial healing. So this is another case in which it was used in a chemical injury with a large corneal defect. So what are the advantages of the amserter? The elliptical design helps conform to the shape of the fornices, and it is deformable yet with good memory, so it does not tend to come out and is not brittle. So while you are inserting it, there are no cases reported till date in which the amserter has broken. You can actually use more than one layer. So we have tried with attaching, and it works with up to 3 layers. Beyond that, the snap-in effect is not so good. And if you want, you can apply glue on the undersurface and put it in, but it is not really required, because there is no chance, unless the patient is pressing on the lower lid vigorously, that the amserter will come out. But if you want to disinsert it, it is fairly easy by putting a speculum and holding the lateral edge with a forceps and nudging it out. So here is a little bit of a testimonial from Dr. James of Mass Eye.
It's not audible.
Okay, then I'll skip this slide.
Okay.
Okay, so this saga of the amserter does not end here with the invention. It actually starts here because we have to educate the critical care specialists and dermatologists to refer acute Stevens-Johnson cases to us. And for our colleagues who are treating chemical injuries, they also have to be made aware of this device. So thank you very much.